Maybe they were in pain. Maybe they were upset, confused, and anxious over being brought to the hospital.
What a concept, right?
A patient has to be sitting comfortably.
You're seeing all generations within the family.
Sometimes, yeah. And his blood pressure is still not controlled.
What you prescribe, what's on a medication list?
Okay, we don't have CAT scans or MRIs at home.
Welcome back to the LifeChoice Hospice and Palliative Care podcast. Today we're joined by Dr. Daniel Gutstein. Dr. Gutstein, thank you so much for joining us.
Thank you, Sarah.
For those who are not familiar with you, can you share a little bit about yourself?
Well, I am a primary care doc. I'm in solo practice, and I do home visits for the homebound.
Excellent.
That's pretty much how we know each other.
Yes, for several years now.
It's been
a bit. For those who, we were talking earlier that not many people know that they can even receive physician visits at home. So I'd love to talk a little bit about that today, but it is a very unique thing to do, I think. And so how did you get into this, doing home visits?
Yeah, it's kind of funny. So I did my residency in family medicine, and, among my medical school clerkships, I did one in hospice and palliative care, and we did home visits there. Okay. And then as a resident, I did a rotation with hospice and did home visits there as well. After residency, I found a practice that I joined. Didn't work out too well, and after about a year and a half, I was looking again. Found another practice that wasn't so much on the up and up and lasted less than a year. And then a social worker I knew at Glenbrook Hospital told me about a practice that she had heard of that paired up doctors with, she said, nurses to go out and do home visits. So it turned out this practice was two companies. There was the doctors group and there was the office support company. The office support company hired techs, paramedics, medical techs, who were the drivers, kept the schedules and so on, and took us doctors or nurse practitioners in tow, and we saw patients. The guy who headed up that business side came by it in the 80s in San Diego. There was an ER doc who noticed that he was getting a lot of frequent flyers from the neighborhood that just had common primary care kind of issues, but they couldn't get out of the home for regular primary care, and they ended up in the ER periodically. So he started a pilot program sending doctors out to the homes, and he cut down the ER usage by a significant amount and established that pattern method of the home visits. So this guy brought it back here in the 90s.
Okay.
I joined them in the aughts. After about 5 years, that company kind of went belly up, and I've been on my own ever since.
Wow.
So since December of 2011.
From, the social work perspective, this type of care, this model of seeing people in their home environment, I'm such a fan of it because you notice things in the home that a physician seeing someone in the office setting simply would never know about.
It's true. I remember being in the office, and there was this one woman who was a patient, younger, horrible pain conditions, chronic pain, and she would come in, and sit on the table. She would cry from the pain. I would assess her. I continued her on the medications she was on. And the thought occurred to me at some point, this is how she presents to me in the office, which is the only time I see her. She has young children at home that she's raising, that she's carpooling. She functions out there in the world, but this is the only way I see her. And I realized there was that dichotomy. I couldn't square the circle. But now seeing people at home, it's a different situation. I meet some of the most interesting people who are no longer doing the things that they used to enjoy. Time takes its toll. But you're right. I see them in their living situation.
I think sometimes when we see patients in the home setting, you see the state of their home, right? Is it, a patient might present well when they leave the home. Maybe they really do their best. This might take all day, kind of preparing for that outing to look your best, to be presentable, to show the world a side of yourself that you want them to see, right? I think it's about self-preservation and wanting to maybe look your best to be the part, but the home environment can show a completely different situation. Maybe this is someone who is developing a form of dementia, who, has some cognitive impairment on some level, dresses appropriately when they leave the home, but has spoiled food in their refrigerator, or there are, safety hazards in the home, or, different things that we can identify in the home setting, again, that you just don't see in the office. Right. So I would love for you to share a little bit about, what are the types of people that you see at home?
So Medicare allows for primary care home visits for someone who requires assistance to get to the doctor's office for primary care. It's a somewhat looser guideline for the doctor visits at home than it is for home health nursing.
Okay.
I'm not as familiar with where the lines are, and these things change sometimes, but that's my understanding. If they need the assistance, sometimes they say if they need the assistance of two people to get out, then that's... And then also, if someone is the primary caregiver for someone who is homebound, that can also qualify them then to be part of that home visit practice. If their absence from the home would cause the hardship for the homebound patient.
Interesting. Which I think is a very common scenario, right? You have people who...
It can be.
Might be, well-intentioned to support their loved one, but they don't physically live with them, or maybe they have other obligations, and they're, that sandwich generation, right? And they're kind of pulled in multiple directions. Having the ability for someone like yourself to come out and see them, support them, provide that medical evaluation support is crucial.
And you're right about insights in the home that you just don't get in the office. A very common diagnosis that plays out in an office setting, hypertension. Someone comes into the office, you check their blood pressure. It's not controlled. You've put them on one medication. Do you max out the one medication? Do you add a second medication? And you bring them back for follow-up a little more frequently, and it's still high. Now you're cranking up the doses, you're adding medications. You don't really know, are they taking the medications? Did they ever pick up the medication from the pharmacy?
Yes.
Do the medications only exist in your chart?
Yes.
Do they end up hospitalized for some other reason? They have the medication list from your chart, and in the hospital they get all these medications, and then their blood pressure bottoms out.
Yes.
I remember a guy that I used to see in, I think it was North Chicago. Lived in subsidized senior housing. This guy was a bon vivant. He loved the ladies. And at the time, this was when I was with the group, and we had a pharmacy that we worked with that delivered. And I remember he had had a stroke at one point. He recovered really well, but his blood pressure was an ongoing risk factor for further problems.
Got it.
And of course, his blood pressure was difficult to control. And he confided in me on one visit that he didn't like certain side effects of the blood pressure medications. I'll remind you, he did enjoy the ladies.
Understood.
Now, the little blue pill was fairly new at this point. I was able to get a prior authorization for his insurance to cover that because contributed towards his blood pressure control to prevent strokes.
Sure.
And one day I'm coming for a visit, and I notice in his kitchen, above the cabinets, there's space between the cabinets and the ceiling. And it's filled with boxes from the pharmacy. So I ask him to take a few of them down, and he looks kind of sheepish. Yeah, there's only one medication missing from any of these boxes. And his blood pressure is still not controlled.
So he knew which ones he wanted to take.
Oh, yeah.
Selective.
Yeah.
Okay. I think that's a great example of seeing the what you prescribe, what's on a medication list isn't necessarily what someone's actually taking.
Yeah. Yeah. Over time, my territory that I visited changed, and I heard from whoever took over that area that he did have another stroke, and he was no longer living on his own.
Got it. You bring up a great point. I've seen patients in the home or spouses of patients who are very stressed, right? The doctor calls, hey, we want you to cut your dosage of this in half, and now I only want you to take a half of this tablet, and I want you to double this one. These are, verbal orders that are given to someone, and great, maybe if they followed it, maybe everything would go well. We had a patient on service who husband's dying, wife is super stressed, doing her best to care for him. The daughter is telling me, we're sitting at a table just like this in the kitchen of the home, and she's like, my mom is she's very stressed, but she's also like so confused. I could probably say, is it related to the stress? Is it related to the grief? It absolutely maybe could be related to that. Then we come to find out the daughter called the doctor's office and, is telling them, well, I'm looking at my mom's pills. She's taking this at these doses. Oh, no. We called your mom last week. We told her she only needs to take a half of this medication. So the patient had been taking twice as much of one medication than she should have, which accounted for her confusion. And I think this is something that's so common, right? I would imagine you see it pretty frequently too.
It happens, absolutely. As doctors, sometimes we think we are being so clear with our instructions, we don't always take the extra step of confirming with our patients or the caregivers that they're understanding what we are saying. It happens.
When you complete an initial visit for a patient, can you share a little bit about what someone should expect when they receive a visit from a physician at home? What does that look like? How does that happen?
Initial visits are different than follow-ups. Initial visits are mostly about information gathering, sometimes setting a plan. Very rarely are there changes to a plan at the initial visit, unless there's something really driving it and the patient has a very clear idea of what they need different than what's happening. So for me, an initial visit can take an hour and a half or two, sometimes longer. There's a lot of keystrokes, documentation.
Yes. I want to pause there because I think for people listening, when you go to a regular primary care doctor, you're not there for an hour and a half.
You might be in the waiting room.
You might be in the waiting room. That's true. But I want to really point that out because I think this is something that really defines your practice and is something that I've received positive feedback from families on, that you do take your time. There's a lot to be said for doing a really thorough assessment. And I want to talk, a little bit about that. I think we've touched on it a little bit about, things you notice in the home, but there's a lot to be said for doing a really good assessment. And it sounds like during those visits, that first visit, that's really what you're hoping to come out of it with.
My main goal at the initial visit is to get as much information as I can. And then it gives context to anything that follows. So if there are calls, emails between that initial visit and the follow-up, or if there's something at the follow-up visit, I already have some context, some understanding for what might be going on, and an idea for changes that might have to happen, things we might have to do differently, things we might have to look into. There are other services available in the home that people are not always aware of. So I work with a lab that will send a phlebotomist to the home so we can get blood draws in the home. They can collect urine also if that's necessary. There are companies that will do X-ray and ultrasound in the home. And ultrasound includes echocardiogram.
Oh, wow.
Or Doppler studies in the legs or arms. So that's all ultrasound.
Wow.
Okay, we don't have CAT scans or MRIs at home.
Not yet.
No, not yet. We don't have those tricorders that they had in Star Trek. I would love to have a device like that first diagnoses and then you flip a switch and it treats. Could be helpful.
Maybe in the future.
Maybe.
Okay. I think, still speaking to the assessment piece, I think something else you have picked up on, which is something we've chatted about, is dynamics within the family, right? And I think you've been very aware of, this person is kind of feeling this way right now. It seems like this and this might be happening. So part physician, part social worker sometimes, which is really, really helpful. For me, I'm like, please tell me. So I kind of know from your perspective what I might be walking into or how to better approach something, who's kind of the informal or formal decision maker. All of those things are really, really good to know when we're doing work with a family.
Okay. So I would never pat myself on the back and say I'm as good as a social worker. But as a physician, part of what I do is I have to make observations. Sure. Sometimes I remember enough to document those observations. Sometimes they don't make it into the chart.
Sure.
But it's still part of, in a sense, the color of the visit. And if I am referring anyone to come into that home, I do want to try to remember and mention anything that might be relevant.
Absolutely.
Some people might be nervous walking into a home where the husband has a gun behind every pillow.
I would say yes. I would want to know that.
Well,
Safety consideration.
Former, veteran, former cop. He's well protected.
Which is definitely something we find.
Absolutely. Then again, and I also had a patient who was a former cop who would never want a gun anywhere near himself anymore. His own limitations. It's fair.
When you see someone in the home, and some of these people are very longstanding patients of yours, and they start to show signs of decline or changes, can you kind of talk through from your perspective how that what that looks like, when these conversations might start to happen with, we're noticing some changes with your mom, your dad, because I feel like, we see it from our perspective, you see it from yours, and sometimes it's the family, of course, has their own perspective, and we didn't talk about that, or, then you speak to the physician, well, we've talked about that 5 times, right? And so people, again, we recognize that people are under a lot of stress. So what I say to them and what they hear might be 2 totally different things.
Definitely true. There are times I might mention something that's a remote possibility that becomes the only thing that they remember from the conversation.
Yes. You said this, right?
And I have to think back, did I ever say that?
Yeah.
I can see where that might be something. It's a lot more fun when people repeat back to me something I said that's really funny. Wow, I said that? That's funny.
Give yourself a pat on the back for that.
Yeah, no, I just laugh.
So speaking to from your perspective, when you have families who, maybe they're aware of changes in their loved one or they're not aware, right? Maybe, because I think sometimes it's very hard to see when you see someone every day.
It cuts both ways.
Yes.
There are times I have had to tell, the adult children of my patients about a specific area of decline that requires attention, might require a specialist follow-up, might require assistance in the home, and they haven't been aware of that. But it also cuts the other way, where every time I see the patient is well put together, conversational, absolutely appropriate, nothing seems out of place, and afterwards I send an email to the power of attorney who responds to me with all the decline that's going on that the patient has hidden from me, and what can we do about it?
Interesting, right?
Yep, both ways.
Not always what it seems.
Right.
Which, again, goes back to that thorough assessment. You're not only taking information from the patient, but also who are the patient's supports,
Right.
who is the defined caregiver, because they can give you a lot of insight into what else is going on.
It's true.
We share this story within our team of, a son calling his mom. He doesn't live in the area. And, his mom answers and, "How are you, Mom? Oh, my goodness. Johnny, I'm doing well. It's sunny today. It's on Tuesday. Tomorrow I have this appointment," and going on and on and on. And the son is like, my mom is with it. You know, she's doing great. She's so active. And then the son comes in to visit, and he's like, what happened? She is super confused. The house is a disaster. What changed so suddenly? And sometimes the reality is nothing changed suddenly, but this conversation on the phone, unfortunately, is just very different from what's been going on, right? You find that some patients who, you know, they can cover really well for some of these deficits. You know, the patient might have been looking at the news that day and said, oh, okay, I know today is Monday, right? And I know to get him off the phone, I can talk about this, this, and this. He's going to be super happy. We're going to end that conversation, and he's going to get off my back, right? Everyone wants, I think, to be very independent. No one wants someone in on their business. But for the children, for example, or whoever is the defined caregiver or loved one, that's really shocking to walk into.
It can be, absolutely, especially the out-of-town.
Yes.
Yeah, it's a tough one. Mm-hmm. You mentioned looking at the newspaper to see what day today is. I had a new patient in one of the assisted living facilities that I visit that I saw last year. Mm-hmm. And initial visit, so trying to get orientation and, you know, do you know the month and the year? Mm-hmm. And she told me with complete conviction that it was July 1973. This was last November.
Okay.
So she was only off by 52 years and a couple months. Mm-hmm. All I wanted to know was what happened that month that was so good that it became her home.
Absolutely. And I think sometimes, depending on the patient's level of cognitive impairment, there comes a point when you can just be there with them in that space, in that right? Moment, yeah. That's their reality. And
it's really funny how they can be up to the minute with you in the moment. Mm-hmm. But if you step back and peel back a layer, you don't know when that moment is.
True. Very true.
Yeah.
I think speaking to just the different layers, I think being in the home setting and having those more long-standing relationships allows you to kind of peel them back slowly.
So I had a patient, her vision was declining. Mm-hmm. I mean, she was 103, living at home alone.
Wow.
Had a daughter in the area, so helped out. Mm-hmm. And she was telling me how she was seeing snakes in the bed. Mm. Okay, so do you mind if I go look in your bedroom? Mm-hmm. So I looked in the bedroom, and of course there's a blanket, a comforter on the bed, and there are shadows, and there's not very good light. She was very reassured when I was able to tell her there are no snakes in her bedroom. But when the shadows are just so on the blankets, that's what she's seeing. And cognitively, intellectually, she understood that. She felt better, that it is the visual impairment causing that distress. And once she knew what it was, she was okay with it.
Wow.
I did recommend she get a powerful flashlight.
Okay.
But
a very a non-medical intervention, but something that could
very practical.
That could make all the difference.
Yeah.
Can we talk about importance of deprescribing?
I wish I were smart enough to deprescribe. We have guidelines for just about every medical condition that by evidence-based medicine have determined that if you have this medical condition, you need to be on these medications, possibly these others as well.
Right.
And if you have these two medical conditions, well, now there are 6 to 10 medications you must be on. But of course, my electronic medical record points out all the interactions among all these medications. And then there are a couple other conditions which mandate a couple other medications. And then there are the medications that address the adverse effects from some of the medications. Every now and then I'm able to remove something to positive effect. Not often enough.
Complaints that we hear are, I'm tired of having pills for breakfast, lunch, and dinner. Right? I might have a poor appetite as it is. By the time I've taken all my medications, I don't feel like eating very much. And so I think, as we were talking earlier, it's really, really common, especially when patients have had multiple hospitalizations, that great at adding medication, not necessarily taking away medication. To speak to, patient going into the hospital, presenting with high blood pressure. Oh my gosh, your blood pressure is sky high. We better put you on something. So then they discharge home. Maybe they didn't have high blood pressure normally.
Maybe they were in pain. Maybe they were upset, confused, and anxious over being brought to the hospital.
What a concept, right?
Yeah, I know. I once read a cardiology guideline that said, in order to check blood pressure accurately, a patient has to be sitting comfortably with the cuff on the arm for 10 minutes before you check the blood pressure. I don't do that. But when it comes time for my exam, the first thing I do is put the blood pressure cuff on. Then I go about and do the rest of the exam, the temperature, the pulse oximeter, the listening with the stethoscope, the poking, the prodding, whatever else. It does buy me 3, 4, 5 minutes. Mostly blood pressures are good enough.
You bring up a really interesting point. When I think about a formal diagnosis, right, and from a clinical social work perspective, to diagnose someone with something, right, we say that it should affect them in a significant way in multiple environments, right? Not just one presenting maybe episode doesn't define a formal diagnosis, which I've never thought about it that way in terms of a medical diagnosis, but that would kind of make sense, right?
In a certain sense. Some diagnoses go with actual data. Diabetes, we track blood sugar.
Right.
Blood pressure, it's high if it's above a certain level. Twice.
Got it.
For the initial. Or if it's high enough, you might want to start reducing that. Weight, you can weigh a person, and if it's a little high for how tall they are, well, that might be a little overweight.
Do you commonly see postural hypotension for patients who are?
Not so commonly.
Okay.
Every now and then I do have a patient who has that.
Okay.
I've had patients on medication for it. It's funny to see in a patient's chart that they're on medication to boost their blood pressure, and they're on antihypertensives.
Oh.
And I just have to start to think, okay, which one do they need?
Right. So like push one down to bring one up.
Yeah. So now,
had
sometimes there are parameters.
okay.
And so you know which is the guiding medication, and you just don't want it to get too far that direction. Okay, fine.
Mm-hmm. We had a patient, the grandson called, and he's like, my 97-year-old grandfather, he's just real sluggish, he needs to be a little more peppy. I'm thinking to myself, what is the, would it be a normal thing at 97 to not be maybe as peppy as you used to be? I would think maybe yes.
Maybe. If you've been peppy through 96 and a half, and now you're 97 and you're sluggish, maybe something changed.
Perhaps.
And maybe it's worth taking a look. Chances are, yeah, you've come by it naturally.
Right.
But we don't know that.
You can rule it out, right?
Yeah.
What would you say is the most rewarding part of your job?
The relationships over time. Every now and then, a patient's child will just thank me for the care I provided. Oh, gosh. Okay, during that dark time, 2020, I had patients that I would see in the home, and their children, again, who are older than I am, were afraid to visit their parents at home or have anyone go in that home. And they were so grateful that I could. That broke my heart.
Yeah.
But I was glad I could visit some of these people who otherwise might not have had visitors.
Absolutely. I mean, by the nature of being homebound, right, and then being, an older adult, right, with maybe multiple medical conditions, you can understand, from the family's perspective of wanting to protect their loved one.
Right.
But that was an epidemic in itself of, social isolation, especially for an older adult. One day can carry on into the next, and you see.
And so much of cognition
Yes.
requires interaction.
And I think, people are so well-intentioned that they want to care for their loved one. They want to support them. Safety, 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 safety.
Right.
On the other side of it is, at some point, probably something is going to happen, but having this dialogue of how do we support them in their ability to live?
Right.
Right? And I recognize that this is, it's not a one-size-fits-all, but I think having that conversation is an important one.
Absolutely. I remember a radio host a bunch of years ago talking about it's important to have input from experts, but it's important to take that expert advice in context. And the example he had was of a fire prevention expert who visited a school and talked about the fire breaks and the importance of certain doors being closed. And this was a warmer climate, this school, and closing those doors cut off airflow. Oh. And so you could see if there were a fire, you would not want that airflow.
Yeah.
But 365 days out of the year, there's no fire. You need the airflow for the kids to breathe.
Kind of important.
So it's good advice in context. and the context is not full-time.
Absolutely.
So, yeah, we need experts, and we need to understand when to take their advice.
Can you share the story of a patient? Maybe, I think we all have these patients who are very near and dear to our heart that maybe for one reason or another, they really, really stuck out. Obviously maintaining HIPAA. But anyone that for one reason or another, they've stayed with you.
I have so many of them. Mm-hmm. There's the couple that I see where he just reminds me so much of my father. Mm. Okay, my dad is doing okay. Mm-hmm. God bless him, 91.
Wow.
92 coming June.
Wow.
Living on his own downtown.
Good for him.
Has a helper a couple times a week who drives. Okay. This patient reminds me of him in some ways. A little younger than my dad, but okay. So that's one way. Mm-hmm. This couple I've been seeing since my first practice out of residency. And sadly, I used to see their son as well. And their son died 2 years ago. Mm. And that casts a pall over the home now. Another one, I started out seeing the father. Mm-hmm. The mother became a patient of mine because, she couldn't get to her doctor taking care of him, mm-hmm. and I started seeing her. And then I started seeing their son as well.
Oh, wow.
He does okay. He's had failed back surgery, so has a hard time getting around. Mm-hmm. The father passed away a couple years ago on Christmas. Mm. The mother is now in a skilled facility, so I no longer see her, mm-hmm. but I still see him.
Wow. Yeah. You're seeing all generations within the family.
Sometimes, yeah.
Wow. And your ability to see them, prior to these really life-changing events, losses, and continue to support them through that. That's amazing.
As a family medicine resident, mm-hmm. I once told one of the ER docs that we were essentially two sides of the same coin, that in family medicine, when we follow up with patients, we kind of have a movie, and when the ER doc sees them, they've got a scene from the movie.
Interesting.
And of course, I never remembered that until she told me about it a couple of years later.
Makes sense, though.
Yeah, it's kind of neat.
Wow. When if there was anything that you would like to share with those listening who might be looking for information, for their loved one, maybe it's their parents, whoever it is, any, words of wisdom that you'd like to share with them?
I think the most important thing to bear in mind is help is out there and available if you need it, and you can find it. That's pretty much what I would say at baseline.
Mm-hmm. And people have options, right? They don't, they can have...
There are options.
Care at home, too. If you're having a problem, ask questions, right?
Right.
Maybe someone knows someone who knows something. Oftentimes, I feel like that's how people get some of the best resources. It worked for someone else who might be in a similar situation to you. And sometimes that's home visits from a physician like yourself. Sometimes that's, finding a really good caregiver. Sometimes that's finding a really good
Sometimes it's just a matter of the office doctor ordering home health. Mm. And sometimes that visiting nurse or visiting physical or occupational therapy is what's needed.
Yeah.
and then someone doesn't need the home visits.
Yeah.
That's a possibility. So I think I mentioned the lab that I work with and the X-ray and ultrasound. And through home health, we can get nursing and therapy. There's actually a company I work with that does outpatient therapy in the home. So therapy through home health has its limits.
Yes.
Outpatient therapy in the home does not have the same limits.
It's more intense, correct?
It can be a little more intense,
Yeah.
but more importantly, and for most people, it can go on a little longer. And they can derive more benefit from it.
Interesting. Again, one of those benefits that I think a lot of people probably aren't aware of.
Right. So something to bear in mind. Of course, if you can get out for your outpatient therapy, okay, maybe that's better because there's equipment that they have in those gyms that nobody can bring into home.
True. Well, thank you very much for your time, Dr. Gutstein.
It's a pleasure. Thank you.
Thank you again, and we'll see you next time.